discussion. Oh, let me see. Got it. Okay. So the objectives are threefold. We're going to talk about being better able to diagnose ADHD. We're going to talk about the better way to assess ADHD. We're going to talk about better ways to treat ADHD. Some of this may be a review for you. Some of you guys may feel comfortable with this. I'm hoping along the way, though, you'll pick up some pearls of stuff like, oh, I never thought about that, or oh, I didn't know that. So just in general, Louisiana as a state has the highest rate of ADHD diagnoses going on. This has been a stat since the year 2013. So this has been going on for the last 10 years, and it hasn't gotten any better. Back in 2014, when they released the stat in 2013, they made an ADHD task force in the state of Louisiana. And from a child psychiatrist perspective, I have no idea where this went. I don't know what changed. I don't know what happened. It seems like nothing changed. Nothing happened. So the rate of diagnosis of ADHD across the nation is, from state to state is about 8 to 12%. 8 to 12% of kids ages 6 to 17 have this diagnosis of ADHD. It's 16% in the state of Louisiana. We are a huge outlier in this, and Mississippi's not far behind, just to make ourselves feel better. The rate in the Medicaid population in Louisiana is 22%. So we have a huge rate of diagnosis of ADHD going on. So we got to kind of question, okay, what's going on with this? Let's talk about it. So your typical case, you have a 7-year-old male struggling with behavior issues in school. His grades are only so-so. The teachers are saying he needs an evaluation, or heaven forbid, the teachers tell the parent, your kid needs medication or they can't come back to school. I've definitely seen this scenario multiple times. Or you have a parent in there in your clinic saying, I think my child has ADHD. Okay, where do you go with this? So how do we diagnose ADHD? Does anyone want to chime in and say, how do you diagnose ADHD in your clinic? What do you do in practice? I think most of the time it's going to involve, diagnostic questions, review of the DSM-5 criteria, maybe some questionnaires from the parents or teachers, maybe, and then you make this diagnosis and you start treatment. That's kind of how things roll, even in a child psychiatrist clinic. We get a little bit more time with the patients. Sometimes we have an hour to do an initial evaluation, sometimes followed by another hour-long evaluation. But typically it's a review criteria, some questionnaires, followed by a diagnosis. It's not, historically we haven't thought of it as too much rocket science behind this. We don't use imaging to diagnose. We don't use any blood tests to diagnosis. And oftentimes my clinic will get the call, do you guys evaluate and assess for ADHD? And the question is yes, but we don't do testing for ADHD. Psychiatrists don't typically do testing. So right here, I want to stop and get us in the right mindset that, and I am guilty of this too, that for a long time in our heads, we've been making these diagnoses of ADHD and it's not a big deal. And I'm here to say we have to stop and we have to change that. And we have to get in the right mindset, because ADHD is a big deal. It is a disability, first of all, and is a lifetime diagnosis. So you make this diagnosis to a kid when they're 5, it carries with them the rest of their life. So this is a big deal. And so if you're having a parent come in and saying, I think my child has ADHD, you want to prep them for that. You want to prep them, okay, this is a big deal. Like we need to rule this out. We need to decide if this is going on, but it's going to be a process. We can't make that diagnosis in a one-stop visit in clinic anymore. If this is going to be a process. And so what is that process? So let's start with the DSM-5 criteria. This is your little review, the DSM-5. We have 2 categories for the criteria for ADHD. We've got the inattentive subtype, and then we have the hyperactive impulsive criteria. You can see, I don't know if y'all can see my pointer. I think you can. In one category, in the inattentive symptoms, we have 9. And then in the hyperactive impulsive symptoms, we have 9 symptoms. To make a diagnosis, you need 6 in one category. It's the rule of 6. So to make a diagnosis of inattentive subtype of ADHD, you need 6 in that 6, at least 6 of that 9 in that category. Now, some patients have 9 out of 9, some patients have 8 out of 9. It has to be 6 or more out of 9 to make a diagnosis of hyperactive impulsive, you have to have 6 or more in that criteria. So you can't have 3 inattentive, you can't have 3 hyperactive, and that's combined type. No, 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 no. It's the rule of 6 in each category. Now you can have, say you have 8 inattentive symptoms and you have 9 hyperactive symptoms, then that's the combined type. That's how you diagnose ADHD. Now there's other specifiers, like now there has to be symptom onset before the age of 12. It has to be present in multiple settings, and this is very, very important. So if you have a kid that the teachers are saying has ADHD, and then at home the parents aren't seeing these symptoms, they don't see this hyperactivity, they don't see what the parents are talking, the teachers are talking about, that's a problem. That's not ADHD. Vice versa too. If you have a kid that's cutting up at home and the parents are coming to you like they can't focus, they're not doing their homework, they're not listening, but yet you get a teacher report and they're an angel at school, that's not ADHD. So that's something else. So it has to be present in 2 settings. It's very important. They love to ask that on the boards. There has to be a significant interference in daily functioning. So for anything to be a diagnosis in mental health, there has to be a level of impairment from their symptoms. And it's not better explained by another mental health condition such as autistic disorder or intellectual disability or something like that. You can have ADHD with those diagnoses too. So I still have patients that come in and say, well, I don't have ADHD, I have ADD. That's an artifact actually from back when it was the DSM-3. So DSM-3 in the 1970s, it was broken down into ADHD and ADD. Nowadays, it is all ADHD. So in the DSM-5, it is all ADHD. And basically, when someone comes in and tells me I have ADD, I'm thinking they don't have the hyperactive subtype, they have the inattentive subtype. So I just want to put that in there because I still see this in practice nowadays. Like I don't have ADHD, I have ADD. Well, it's actually all called ADHD now. So in an ideal world, how are we going to work this up? Well, in an ideal world, we would start reviewing all their academic material. We would review their report cards, everything we could. We'd review report cards, we'd review progress reports, we would review any sort of teacher report, behavioral reports. If they have those little checklists, where it's the red, yellow, green behavior, we're going to review that. We're going to see what's going on in class. We're going to review the DSM-5 criteria for preliminary diagnoses. We're going to have the parents and teacher complete rating scales. Now, back in the day, we used the Vanderbilt rating scale, we used the Connors rating scale, we used the Brown. The problem with the Connors and the Brown, you have to buy the package. You got to buy them, and it's expensive. And so we've moved towards using just the Vanderbilt because it's free and it's online. So it's kind of easy to print out and give to parents and teachers. So that kind of dictates what the screens we use. In an ideal world, we would have every young child sent for academic testing, and that involves an IQ test. Because if you have a kid with an average IQ, say you have this kid struggling in school, they're making B's and C's in school, their parents thinks they should be making A's, occasional D, but you test them and you get them IQ tested and they have a very, very average IQ, like 100 IQ, then B's and C's are what they're capable of. That's not ADHD. This is what they're capable of. Let's fix those expectations of these parents and have those reasonable expectations for academic performance. You're going to do adaptive functioning testing with the IQ testing. Those two go hand in hand because if you have a low IQ, the adaptive functioning kind of dictates if this person is actually falls into like low IQ or versus falls into an intellectual disability range. That adaptive functioning can kind of dictate that. Achievement testing are the testing they do in school. So you're going to review those achievement tests that they get at the end of the year. Some schools use MAP testing, some schools use LEAP testing, because that's going to also kind of dictate how they're performing in school. And then ideally, you'll also do continuous performance. They'll have continuous performance testing, which we used to nickname it the X test in residency. And basically, a kid sits in front of a computer screen for a pretty prolonged period of time. It's like at least 20 minutes long. It's a pretty boring test. And letters pop up on the screen like A, D, Z. And every time they see an X pop up, they're going to hit the space bar. And so it's a measure of sustained attention. And then you get a readout of how accurate they were. If they're just like giving up and like hitting the space bar over and over again, the testing, the software comments on that too, like the effort wasn't there and stuff. So it's just another added test to rule out ADHD. And then ideally, in an ideal world, we would also have a classroom observation. We would either have a provider or someone from the school that could go in and do a classroom observation to give their comments on like the kids' level of attention and focus. Now I can tell you, I'm a child psychiatrist, and how many times I've done a classroom observation outside of residency? Zero. So again, this isn't an ideal world. And then finally, and then after we gather all this material and review it, then we would make the diagnosis of ADHD. And then we would apply for our 504 accommodations in school. And we're going to review that in a little bit. And then we would start medication. So who does this? And again, in an ideal world, a general practice doctor would do the initial screening for ADHD and refer to a child psychiatrist who would then I would refer to a child psychologist for the testing, and me and the psychologist would confer on the results of the testing and the treatment plan. It's not going to happen that way though, because one, there's only 92 of me in the state of Louisiana. Louisiana only has 92 child and adolescent psychiatrists. So there's no way we can see everyone that needs to be treated for ADHD. And there's a few more psychologists than we are, but the waiting list for testing are tremendous because these tests take a long amount of time. They're over the course of multiple days, multiple hours of time. So what happens in the real world? We skip all these steps. So we don't review all the report cards and stuff. We do review the DSM-5 criteria for ADHD. Sometimes we get rating scales, and sometimes we get those completed, and sometimes not. Sometimes we just go on criteria in our clinic and what the parents tell us in clinic. And then we jump right to medication management. That's what often happens. Now, what's wrong with this approach? So this was a nice little article you can check out later that was released by Ochsner in New Orleans, commenting, but this approach tends to lead to the overdiagnosis of ADHD. It also leads to the overprescribing of ADHD medication. That's kind of where the boat we're in with the stimulant shortage right now. And that's for other reasons too. What was interesting about this article too is that when it came to those questionnaires that you're supposed to have the parent fill out and supposed to have the teachers fill out, that only 10% of pediatricians in the study actually got those questionnaires filled out. So if you're feeling guilty that you're not doing the questionnaires, don't feel guilty because a lot of people aren't doing the questionnaires. So, but after this talk, I hope that that changes. And then, of course, this approach misses whopping other issues. You're going to miss trauma. You're going to miss learning disorders. You're going to miss autism. You're going to miss intellectual disabilities. You're going to miss psychosocial issues like bullying. You're going to miss crappy schools. You're going to miss stuff like home life chaos. So you're going to miss a lot of other things with this approach too. But we are under pressure as providers. We're under pressure because the kid might be on the verge of expulsion or on the verge of failing. We're under pressure because there are long waiting lists for psychological testing. So I'm here in Lafayette, Louisiana, and the soonest we can get a kid in for psych testing is 2 months. That's not so bad. I know in New Orleans, the lists are like 6 to 12 months in some places. I just want to remind you too, if the kid's in a public school, the parish school board is supposed to offer psychological testing through the school board, through the pupil appraisal center. So that is a resource that you can lean on if the kid's in a public school system. But what if the kid's not in the public school? So a lot of the private schools don't offer testing. They don't do accommodations. So then there's added pressure to treat ADHD without all these other interventions that can be done. And also there's long waiting lists for mental health providers too. So ideally you want, if you're trying to make this diagnosis of ADHD and it's a process, you want to send them to a mental health provider. You can't find mental health providers in the state of Louisiana. There's not enough. So we're under pressure to make shortcuts with diagnoses. This is a snapshot of the Vanderbilt. This is the one I use because I like it for a few reasons. It's easy. It's broken down. The first 9 bullets are the criteria. Those are those 9 criteria for the inattentive type of ADHD. The next 9 criteria, so 10 through 18, are the criteria for the hyperactive impulsive subtype of ADHD. And then the next 5 criteria are oppositional defiant disorder, which is it's very good to tease that out from ADHD because the two tend to go hand in hand. And then the ones under oppositional defiant disorder, you have the criteria for conduct disorder. And then there's like 3 screening questions at the end, and it's cut off from this about anxiety and depression. And again, the Vanderbilt is free. So that's why we like it too. There's also on the teacher Vanderbilt report, I don't have it on here, but on the teacher report, there's a small section in the back where the teachers can comment on how the student is interacting with their peers, with their parents, and how they're interacting and how they're performing in school in reading, math, and I think extracurricular activities are on there. So this is your teacher's opportunity to report back to you like, oh, it's really a peer issue, or oh, we think it's a parenting problem. They kind of have an opportunity to fill that part out on the Vanderbilt. So that's why I like the Vanderbilt. So this is an actual Vanderbilt that I completed on this young lady. She's a teen. She's 13 years old. She's actually in a therapeutic boarding school, and we're trying to rule out if this teen has ADHD. So this was the parent report. You go to calculate the score, you go on just the 2s and 3s. So if we're looking at the top part, those first 9 criteria for the inattentive subtype of ADHD. I put my line in the wrong place, sorry. She's got 1, 2, 3, 4, 5, 6, 7. So she's got 8 actually. So 8 of the 9 criteria. So she qualifies as a preliminary inattentive ADHD. And then for the next 9, she's got 1, 2, 3, 4, 5, 6, 7, 8, 7, sorry. So she qualifies for the combined subtype of ADHD based on parent report. But you got to remember the 2 setting rule. Also, if you look further down, she also qualifies whoppingly for oppositional defiant disorder and probably bordering into conduct disorder, which is likely why she's at a therapeutic boarding school. So keep that in mind. The next slide is what if the parent and the teacher report don't agree? So you got to remember that 2 setting rule. It's very, very important. So this was the teacher report. So this is the teacher that sees the girls at this therapeutic boarding school. There's only about 20 girls in the class, so it is a smaller classroom. Teacher does not see ADHD symptoms at all. Maybe a few careless mistakes. So based on these Vanderbilts, you cannot make the diagnosis of ADHD for this child. So what do you do with that? So for someone like this, you would either need more information, more teacher input, but there's only 1 teacher at this school. So you would send this, I sent her for psychological testing. And so that therapeutic boarding school in particular has a psychologist that does the testing for the school. So we're lucky in that aspect. But based on this Vanderbilt, you can't diagnose ADHD. I'm going to skip this part. I'll come back to this if we have time. But sometimes just to build rapport with students, if they come in with their backpacks, I'll say, let's go through your backpack and let's see how organized you are. And sometimes you can kind of get a sense of this child who has ADHD by their organizational skills, that their backpacks look like the one in the picture. Or sometimes like in their photos, they'll have their actual behavior reports and you can kind of see, oh, you were on red all week. Oh, what was going on there? And so it's a nice little tool to get them to talk and kind of get a sense of their organizational skills. So you've done your Vanderbilts and they actually agree. The parent and the teacher report actually agree. Their parents are saying the kid meets the DSM-5 criteria. So you have a preliminary diagnosis of ADHD. And I encourage you to use that verbiage. You have a preliminary diagnosis of ADHD. You can make those suggestions of getting psychological testing. But while we wait, since you have this preliminary diagnosis, we're not going to delay treatment. We don't want to delay treatment because of the acuity, the situation, and the waiting list to get in with providers. So now what? You have this preliminary diagnosis. Now what do you do? Slides like this give me a headache. We're not going to go through all these things, but there are a number of home-centered interventions that can be done. The important thing about this slide, if you do start looking individually at the bullet points, it's all parenting. So the parents need to be involved in the treatment of ADHD. The parents need to be able to help their children learn these skills at home. things like providing a quiet study space for them, helping them learn, helping them keep to a schedule, um, being specific about tasks and instructions, making eye contact at their level when you give a verbal command and not shouting it across the room, because a child with ADHD is not going to hear you and not going to listen. So that's the first interventions, home interventions. Then it's coming. Then there's school-centered interventions. So a huge piece of treating ADHD is communication with the school. The parents need to talk to the teachers regularly. They may ask for like a daily behavior report as we're trying treatment. If we're going to try it, especially if we're going to try medication, the teachers are the ones with the kids during the day. So we need that teacher feedback to know if medication's working, to know if the interventions at home are working. We need that teacher feedback. So there needs to be communication with the school. Even the seating arrangement may need to be changed, where the kid is sitting next to the teacher and not in the back of the classroom and things like that. And then other than school interventions, they also need to know the law. So if there is this diagnosis of ADHD, again, ADHD is considered a disability. It's a lifetime diagnosis. There are laws protecting kids with ADHD. So first of all, the Section 504 of the Rehabilitation Act of 1973, it requires public schools that get funds from the federal government that they meet the needs of students with disabilities. And they must meet these students' needs as completely as they do for students without disabilities. So that's where that 504 plan comes in. And we'll go through a 504 plan briefly in the next few slides. And then if the ADHD is severe enough and it's disabling enough, the IDEA law protects them as well. And that the IDEA law requires that schools must provide a free and appropriate public education to any child who has a condition that qualifies as a disability. ADHD is included as a condition that may qualify a child for special education services. So if the ADHD is not responsive to treatment with medication or behavioral interventions, then that student, and it's severe enough, that student could qualify for special education services, and they're protected under the law for these special education services. So it's important to empower the parents that these kids do have certain protections with this diagnosis. So these, I'll pop up, if I can pull it up on my screen. This is what a 504 plan looks like. Can y'all see it? I'm still screen sharing. Oh, new share. Here we go.
We see a green box with, there it goes. Okay.
There it is. Okay. So this is what a 504 plan looks like. It's confusing as heck because a special education plan is called an IEP. That's an individual education plan. A 504 plan is also called an IAP. So that's individual accommodation plan. That is confusing as heck for me, for the parents, for the kid, for everybody. But a 504 plan, it's pretty extensive. But you can see on here, ADHD qualifies it as well as other mental health diagnoses. There's also medical diagnoses that are included in these. And there's all sorts of interventions that can be checked off. There's interventions, accommodations for the setting, accommodations for presentation, like the you can get graphic organizers. Importantly, for standardized testing, they can get 504 accommodations, so extended time for the LEAP. And that's super important for these kids. And so this is what it looks like. Normally, this doesn't require a parent meeting. Goodness, my internet froze. Can y'all still hear me?
Yes, we lost you for a minute, but okay. Yes, we can hear you.
I know, I think my internet just kind of pooped out for a second, but we'll go back. Okay. So with the 504 plan, it doesn't require a parent meeting. The parent does have to sign off on it. Now for an IEP is a higher level intervention. That is an individual education plan. It is special education, and an IEP plan has to be updated every 6 months, and it involves a meeting of the team of providers. And so that's kind of how you can distinguish with a parent if the kid is just getting 504 accommodations versus if they're getting special education. Like a child getting special education knows it because they have those IEP meetings, and the parent and all these providers, all these staff from school have to be there for those meetings. It's a big deal. So let's talk about child-centered interventions. So if you have this preliminary diagnosis of ADHD, you're going to continue to await psych and academic testing for IQ, adaptive function. The first line intervention for kids 6 and under is going to be behavior therapy. So I put an asterisk, or even individual therapy with social skills training, organizational skills training, and memory skills training, but also behavior therapy. And I put an asterisk by behavior therapy because it's not really individual therapy. Behavior therapy involves the parents. The parents have to be involved with it because it is all those things that I said are home-centered interventions. It's all that, and having a professional making sure that they're compliant with all that. And then child-centered interventions involve medications, and we're going to spend a good bit of time talking about medications. But before we move into medications, does anyone have any pressing questions? Anything about IEPs, 504 plans, home interventions?
If you're more comfortable, you can type them in the chat and I can pass those on.
I have a question. Just curious, for the 504 or IEP, if the parent asks you for your opinion on different things, are there particular things that you should be making sure that is on the 504 or the IEP?
So technically the school is supposed to do that assessment. The school is supposed to assess, like with the teacher's feedback, what interventions are needed by the kid. But I can tell you that schools love when I check off those interventions. So schools love when I send the letter, you should evaluate this kid for 504 accommodations and they should have extended time with tests. And I lay out which of those 504 accommodations I think fit. Technically, though, the school is supposed to meet with the kid, meet with the teachers, and decide on those interventions, but it just makes their job a little bit easier if I lay those out for them.
I also have a question.
Yeah.
In that evaluation, the child that had the high score, even for the oppositional defiant screen, and then the conduct disorder. So what do you do in those cases? Like, how do we then give a preliminary diagnosis? Because I'm a family physician, so.
We are going to talk about that at the end. I do have a slide just for that too, because that is, let me tell you, oppositional defiant disorder and conduct disorder, those are head slapping diagnoses. Like those, they are so difficult to treat. Because a lot of it is parenting, a lot of it involves parent training, and you have to have a team-based approach when it comes to those. But we will get to that in a later slide.
Okay.
That's a good question.
Yep.
All right, I'm going to move into medications. So there's a ton of ADHD medications. This is where Big Pharma decided to explode. They just went in that direction. There's so many new ADHD medications, I can barely keep up with them. And insurance doesn't pay for all of them, so it makes it very difficult. The way I break down medication in my head, there medications that work within days. So that's going to be your stimulants. There's medications that work within a week. Those are going to be your alpha agonists like Intuniv and Capvay. Technically, you guys, I know we use clonidine and guanfacine for ADHD, but they technically aren't FDA approved for ADHD treatment, but then insurance does approve them, so it gets very weird. But technically, the long-acting alpha agonists are the ones that are approved to treat ADHD. There's a new medication, and I have no stock in this medication, just full disclosure, but I have to bring it up because it is pretty new and it is pretty different than anything we've had before. Qelbree is kind of the new Strattera atomoxetine. Atomoxetine typically takes about 2 months to work, 8 weeks. And so they came out with Qelbree, which is like the new atomoxetine, and it works within 2 weeks. So atomoxetine has a place and it's a good medication, but it takes forever to kick in. It takes forever to work, and it has a ton of side effects. And so then they came out with Qelbree recently in the last year that only takes 2 weeks. So it's a little bit shorter mechanism of onset. So it's a little bit more helpful in that aspect. So we got medications that work within days, we got medications that work within a week, and we got medications that work within a month, and then within 2 months. So how do you pick? Like, where do you start with this? First of all, just to review this is very important. This is one of the what do you call them, hallmark studies in child psychiatry was the MTA study. It was the treatment of ADHD study. It was a huge meta-analysis study. They broke down the treatment groups into 4 arms. One arm got medication only for ADHD. One arm got medication and therapy. One arm got therapy only. And then one arm just got community resources. What they found was that the 2 groups in the short term, the 2 groups that got medication did just as good, did much better than the other 2 arms. And the 2 groups that got medication did just as good as each other in the short term. The graph I have on here is the long term. The long-term follow-up was that the 2 groups that got medication, so the combined therapy and medication group and the medication group, they both did the best long-term, but the combined group, the group that got a little bit therapy in the long-term did a little bit better than just medication alone. So what does that tell you? For the longest time, that told us, medication alone was probably adequate enough to treat ADHD if it was truly ADHD. And you have to remember in these studies, it is just pure ADHD. If they have comorbid ODD, they're going to be ruled out of these clinical trials. If they have comorbid anxiety, they're going to be ruled out. So this was pure ADHD, responds very well to medication. But in the longer term, it is best to combine medication with some sort of therapy. So when I have parents that come into my clinic and they say, I don't really want to put my kid on medication for ADHD, I'm like, that's okay. We can do just therapy alone. Even in the MTA study with behavior with behavioral treatment, that's therapy alone, after 14 months, 30% of them did improve their symptoms. So I can tell the parents that you will see some improvement. It's going to, if you don't want to do medication, you will see some improvements, but it's going to take therapy and it's going to take long-term therapy. But there is a very strong argument that ADHD, that if it is ADHD, medications do work. And they work pretty well too. So how do you choose which direction to go? How do you choose if you want to start with Strattera or something, a non-stimulant versus a stimulant? And this depends on so many different things. This depends on parent preference. I have lots of parents who like, I don't want my kid on a stimulant. Let's go with the non-stimulant. That makes it easy. I don't have to make that choice. The time frame and the acuity of the case make a big deal. So if you don't have a couple months, if this kid is on the verge of failing and on the verge of expulsion, you don't have a couple months. You got to make interventions quickly. So in those cases, you're going to lean towards stimulant. The access to other interventions. So if this kid's in a public school where an accommodation plan can be done and implemented, you might do that and therapy before you start medication at all. Or you might do therapy with the accommodation plan and a non-stimulant first. So it just depends on the access to interventions. Now, the other kids in private school settings that in school settings where they don't do accommodations, and not all, and some private schools do accommodations, don't get me wrong. But if they don't have access to other interventions, you might want to choose the short-term option there. If there's comorbidities, specifically anxiety or substance use, you're going to choose a non-stimulant first. The size of the kid and their appetite make a big difference. So if you have a scrawny kid who doesn't eat well, you're going to go with a non-stimulant first. And then the presence of sleep issues, something you don't often think about. But if you have a kid that's already not sleeping, putting them on a stimulant is not going to make that better. So you might choose to opt for a non-stimulant first with that in that sort of situation too. So all those factors kind of come into play when you're choosing medication. And then the certainty of the diagnosis comes into play. So if you're uncertain about the diagnosis, so this is a preliminary diagnosis and you're really not sure this is ADHD, you might want to start with a non-stimulant first while you continue to collect that data. And you're going to prepare the parents like, this is a process. We need to collect more data. Let's not hold off on treatment. Let's start some interventions now. We can start a non-stimulant now while we continue to collect all this data. And so let's review medication principles real quick too. I go through these with patients when I see them, when we're talking about medication. It is a trial and error process. So kids definitely feel like guinea pigs when they're going through this, because what affects this kid in this way may not affect this kid in this way. It is completely trial and error. We're going to try one thing. If it doesn't work, or if it only partly works, we're going to try something else, and we're going to try something else, and we're going to try something else, and we're going to try something else. Like it is a process. The general principle is to go low and slow, but it doesn't have to be terribly slow. It honestly depends on your clinic availability. But can you see this patient every 2 weeks while you're doing this? Can you see them every month while you're doing this? The standard, from the American Academy of Pediatrics is that they need to, when you're initiating ADHD treatment, you have to see them at least monthly. And if you can't do that in your clinic because it's so busy, then you might need to refer them to a specialist, and they might have to wait for a specialist to do this right. The general principle is that you're gonna push that dose up of medication until you either hit side effects or you hit efficacy, which means it's working. And the MTA study kind of backed that approach up, that the higher you could push up the dose, the better the kid did. Kids have very fast metabolisms and they tend to eat through medication pretty quickly. It tends to get in and out of their system pretty quickly. So the younger ones tend to require higher doses than the older teens. So just be prepared for that. And then I prep my patients. School feedback is critical. We cannot do this if the school's not going to give any sort of feedback, if the teachers aren't going to give any sort of feedback. Child feedback is critical. So if the kid's complaining of stomach aches, the parents need to listen. That, yeah, maybe their grades are stellar, they're doing great in class, but if they're complaining of stomach aches every day, we have to have that trust that we're not going to continue this medication that's making them ill. We have to have compliance with medication. Like if it's working, they need to take it every day. Or if they're not having side effects, they need to take it every day. If they're not taking it because of a side effect, I need to know that, and that we need to address it. And then active feedback is critical because these medications have a lot of side effects. And so the parents need a way to be able to communicate with you between visits. So I know in busy primary care, if you're only seeing them like once a month, they need a way to reach you, or a nurse or someone who works directly with you, a medical assistant, in between those visits. And you need to establish that early on, like, this is how you're going to reach me. Like if your kid stops eating on this medication, if your kid can't sleep at night on this medication, you need to know that sooner than later. So let's talk about stimulants a little bit. There are two broad categories of stimulants. There are the methylphenidate derivatives and there are the amphetamine derivatives. Neither class is better than the other one. Both classes have the same side effect profile, and we're going to review some of the side effects and how to manage those. So the door is wide open when you're choosing a stimulant medication. So just so you know that. We've got short-acting stimulants, and then we have long-acting stimulants. There's no one of those is better than the other one. So I am going to give you a little bit of guidance when it comes to choosing medication. I love this. This is a free resource. It's a free PDF, and it looks like this. It's all the ADHD medication. There's 2 pages. There's a front and a back. And they keep it up to date. So this one, you can see it was revised September 1st, 2023. They update it every single year. And so when I have a kid that comes in and they're on, let's say Concerta, and they don't know the dose, and I'm like, well, what does it look like? And they're like, oh, it's the little white one. Okay, you're on 36 milligrams. So I find this chart is super helpful. It does not have all the generics on there, though. It doesn't have all the generic pill pictures on there. But if they're taking something like Concerta, Focalin, Quilichu, like it'll help you identify what medication they're taking. I want you to note this. All these medications are methylphenidate formulations. They are the same chemical, just repackaged in different ways. So Concerta, Cotempla, Actenzio, Quilivant, Ritalin, Metadate, and the ones at the bottom, Ritalin, methylphenidate, it's all methylphenidate. So that, to be in my head, I conceptualize it as that. So as I'm trying and trial and erroring medication, I'm not going to go from a methylphenidate to a methylphenidate if they're having side effects. I'm going to make sure we do something different. So the other ones in this class that stand out are dexmethylphenidate, which is Focalin XR or Focalin, period. And this new one, Astaris. This was a brand new like type of medication, which was serdexmethylphenidate. It's a new compound. So if I'm moving through the methylphenidate, this side of the chart, I'm thinking methylphenidate, serdexmethylphenidate, and dexmethylphenidate. So there's those are three different types of medications. And then we have the other side, which is the amphetamine derivatives. And for the longest time, there was only Adderall and Vyvanse, and it was super simple. And now we have all these medications, and it's super confusing. Just note, like if you look at the tiny, most of them are mixed amphetamine salts. So you have D and L amphetamine, you have D and L amphetamine, so mixed amphetamine salts, mixed amphetamine salts, mixed amphetamine salts. So all these are just mixed amphetamine salts. So these are all very similar compounds, except for dexedrine, which is dextroamphetamine, and then Vyvanse, which is lisdexamphetamine. So on this side of things, on the amphetamine side of things, you kind of have three different types of amphetamines. You have lisdexamphetamine, you have dextroamphetamine, and you have mixed amphetamine salts. So that, and I'm only pointing this out to you to sort of help guide treatment later on when I give you the algorithm. So when it comes to methylphenidates and amphetamines and choosing medication, what the data shows us, if this is ADHD, as you choose one, you choose a stimulant, so you choose Adderall to go with first. There's an 85% chance that that medication is going to work. That's a pretty high chance it's going to work. And if it doesn't work, you're going to switch to the methylphenidate, you switch to a different class, and there's a 95% chance that that's going to work when you switch classes, because if the diagnosis is ADHD, it is going to respond really well to stimulant medication, typically. Now, there is a nice little algorithm. There have been organizations that try to come up with an algorithm to treat ADHD to make things more easy on you. And I'll tell you, I use this in my practice. It looks confusing, but when you have time, take a look at it and look at what the little, like the AMP, what does that mean? That means an amphetamine preparation, a methylphenidate. So when you've done your diagnostic workup, you're going to choose medication. You start with a methylphenidate or an amphetamine. If you try it and one of them doesn't work, or if it's only partially effective, it kind of works, but it kind of doesn't, you're going to choose the other class. So you started with the methylphenidate. If it doesn't work or it kind of works, you can switch to amphetamine. If it doesn't work, kind of works, you can switch within those classes of amphetamines. So if it was Adderall, you might switch to Vyvanse. So if it was Adderall was mixed amphetamine salts, you might switch to Vyvanse, which is lisdexamphetamine. Or if you were in Ritalin, they had a better response on the methylphenidate, you might switch to dexmethylphenidate. So you're going to switch within those classes. The general principle is to try 3 different stimulants before you rule out that stimulants are going to work. Usually, so in my head, my algorithm is set by what insurance pays for. So when I was living in New Orleans and working in the strictly Medicaid clinic, Medicaid only paid for 3 stimulants. They paid for Concerta, Adderall, and Vyvanse. And so those were the 3 that we would try. And if those, once you've tried 3 stimulants, you can see, so step 1 is try methylphenidate amphetamine. If it doesn't work, you try another stimulant. If it doesn't work, you try another stimulant. And then if after you've tried 3, then you move to Strattera, which is atomoxetine. You try a non-stimulant. The only thing I don't agree with on this chart that I've changed in practice, you'll see that the alpha agonists are down here at the bottom. And remember, the alpha agonists are Intuniv or Capve. I would move these up here with bupropion or a tricyclic antidepressant. I see those as a viable option after Strattera if Strattera is not working. I see those as a viable option to try something like Intuniv instead of bupropion. I don't use bupropion in kids, generally in kids under 14. Bupropion is only FDA approved for ages 18 and older. It is FDA approved for adult ADHD. So if I'm using it in a kid, it's off label. And so I don't use it in the younger kids too much. It's just my comfort zone. So in a younger kid, I would lean more towards Intuniv or an alpha agonist at this stage of the algorithm. But I hope that kind of helps guide some treatment for you. And then what about these kids that you see that are like on multiple medications for ADHD? So what do you see these combinations of like kids on, okay, they take Adderall XR in the morning, they take a booster dose of Adderall 5 milligrams in the afternoon when they get home from school, and then they're on guanfacine at night. Where is that coming from? Like, how did we get to that? And the way I want you to see it is as managing side effects. That's how we get into polypharmacy with ADHD. Usually if a kid's on multiple medications for ADHD, it's to manage side effects. But here's the thing. If we find an ADHD medication that works for a kid, side effects are mild, and they're improving in school, their behavior is improving in school, we want to stick with it. We want to hold on to it and stick with it. So sometimes if the side effects are mild, we will just manage those side effects. And so that's when you kind of get into polypharmacy. So how do we manage some of those side effects? I'm going to roll through these pretty quickly because I do want to have time at the end for discussion. So insomnia, first step, decrease the dose of the medication, switch the class. So if they're an amphetamine, you switch to a methylphenidate and vice versa. I have my patients try at least 2 over-the-counter sleep aids. Melatonin has a lot of evidence-based data that shows it's effective as a sleep aid in kids with ADHD. They can also try something like valerian root, chamomile, lavender, magnesium, or even Benadryl. If those don't work and the kid's still not sleeping, we could do some clonidine, some short-acting clonidine at night, or some short-acting guanfacine at night. If those don't work, then we would try maybe a low dose of hydroxyzine, which is Vistaril, a low dose of trazodone, or a low dose of mirtazapine if they're not sleeping. But that's sort of the order I would go in to manage insomnia. Same thing with appetite suppression. If they have decreased appetite, first step, decrease the dose, switch the class. You want to make sure they're taking the medication after breakfast, so at least they get breakfast in. You want to make sure, even if they're not eating lunch, a lot of times they don't eat lunch, they get those 2 meals at the end of the day. So they're at least getting their calorie content like once the stimulant wears off. Sometimes we'll use cyproheptadine in practice. We'll get them to take 2 or 4 milligrams in the morning. You can't do before meals because they're at school. So in the morning or in the evening when they get home from school, or twice a day. And sometimes if they have sleep issues with appetite issues, we'll add on some mirtazapine at night because it has a strong side effect of increasing appetite. Another common side effect, rebound agitation. So when the medication wears off in the afternoon, they're getting super hyperactive or super aggressive or super bouncy. Different ways to manage that. Again, lower the dose. So if they're having these side effects, that's a sign the dose is too high. Just keep that in mind. Lower the dose, switch class. Add a short-acting booster at the end of the day. So if they're on a long-acting methylphenidate, add a little short-acting methylphenidate, like a 5 milligram, 2.5 milligram dose when they get home from school, and it helps to taper the medication out of their system more gently. You can add a little bit of guanfacine or clonidine at the end of the day to manage that rebound agitation. That's usually pretty effective. And so for aggression, so say they're getting aggressive on the medication, but they're doing better in school. I find aggression is pretty common in kids on the amphetamine derivatives. So if they were on an amphetamine and they get aggressive, I would jump to a methylphenidate. So again, switch medication or switch class of medication. I've had kids get aggressive on a methylphenidate, and switching them to an amphetamine helped and it got rid of it. So you want to at least try switching classes. You could add a little bit of Intuniv, so long-acting guanfacine in the morning can help with aggression, help with the agitation. If it's really bad, but the stimulant is really helping, then you can add a 2 milligram dose of Abilify. Abilify is FDA approved for the irritability associated with autistic disorder in ages 6 and older. So we know Abilify is a pretty safe medication on down to age 6. It does come with its own side effect profile though, but it is a good medication. You know, it has an FDA indication in autistic patients, but we've kind of taken it and run, and we use it for a lot of aggression too. You can consider risperidone, which also has a lot of data backing it for aggression, but you always want to worry about it with boys, gynecomastia, and hyperprolactin, because I've seen it in practice time and time and time again. So you got to watch out for that. So I tend to avoid Risperdal these days. Zombieism, personality dampening is legit on medications. You'll have, if you talk to anyone that's been on ADHD medicine, some of them will tell you, I felt like a zombie. I felt like I had no personality. I felt like I couldn't talk to people. It's legit, and kids do not like feeling that way. So to manage that, lower the dose, switch the class. So you see the pattern here. You always want to try lowering the dose or switching the medication. Give holidays and breaks. I have this one patient who's doing fantastic on Focalin. It truly helps her grades, but it dampens her personality. She can't talk, and so therefore it's affecting her friendships. And so we and her mom came up with a plan to do Focalin free Fridays. So she gets one less day at school on Focalin to like be her bubbly, talkative, outgoing self. We told the school about it, so the school was prepared for it. So they're a little bit more lax on those Fridays that she's off of medication. They know what's going on, why she's so different, and she loves it. It was a great idea. It's working out really great. Growth loss. This is a legit concern in growing kids. Stimulants do cause growth suppression. You'll see mixed data about it, but I see it all the time in practice. It's supposed to cause growth latency, so it delays their growth phase, but there's no way we can measure how much growth like how tall would that kid have been had they not been on the stimulant. There's no way we know that. So you have to watch out for this. I've had kids in practice stop growing when they're on their ADHD medication. So what we do, we lower the dose as much as possible. If they were on a long acting, we switch to a short acting so it's in their system for the least amount as possible. Or we switch to a non-stimulant. You really, and sometimes it's just an absolute necessity. If they're not growing, if they're falling off of the growth curve, they can't take the stimulant. And we try to give as many medication breaks and holidays as possible, like off the stimulant for the summer. For time's sake, I'm gonna roll through these slides. And protect sleep, because remember, growth hormone is released in sleep, so we want to make sure these kids are sleeping. So these aren't side effects of medication, but you got to watch out for anxiety. If there's comorbid anxiety or substance use, you want to use a non-stimulant. If sometimes for anxiety, we also would add an SSRI or add therapy with it. For substance use or suspected diversion, we'd switch to a non-stimulant, or maybe if they have to be on ADHD medication, maybe, or a stimulant, something like Vyvanse, where they can't, even if they break it open, they can't get high off of it. And you can also in clinic monitor urine drug screens to make sure the medication is in their system, because if they're diverting it, it's not going to be in their system. So behavior. So oppositional defiant disorder and conduct disorder are common with ADHD. So what do? So you have to insist, you know, if this is ODD, so going back to that Vanderbilt where there was obvious ODD, you have to insist on behavior training. Like your child, you have an exceptional child when it comes to behavior. Like you have an exceptionally difficult child. And in order to help your child, like you're going to have to take a team-based approach. Like your child's going to have to do some therapy, and you're going to have to do some parent training to help with this kid. Because it's a behavior disorder, you got to work on the behavior, and you got to get the school on board. You got to get your family on board. You have to take a team-based approach for this. And that's kind of what I prep the parents as. You have to be, as a clinician, you have to be firm on what symptoms are ADHD and what are ODD. So you got the parent coming in saying, well, my kid pulled a knife on his sibling. That's his ADHD. He's so impulsive. My job is to say, no. They are very clear in the DSM-5 about what impulsive criteria are for ADHD. And impulsivity they're talking about with ADHD is like the climbing when it's not appropriate, or the blurting out answers to questions, or interrupting conversations. It is not pulling a knife on their siblings. But let's talk about this other diagnosis called oppositional defiant disorder or even conduct disorder that does include pulling a knife on your siblings. So you have to be very firm about what is ADHD criteria and what is ODD criteria. And then there's all kinds of strategies for handling oppositional defiant kids. But the most important thing that I can drive home to you is parent training, parent training, parent training. Like everything on this slide that, and I just put this on here because I was like, everything on this slide is everything that parents have to do. So it's all about parent training to manage oppositional defiant disorder. So again, I think that's where we'll stop. I'll open it up for questions. If you have a non-cooperative school, you would refer to Families Helping Families. This is a statewide organization. There's branches in all parts of the state. So if you remember, these kids are protected by the law under the Individuals with Disabilities Act. So these families, they're families with kids who also have disabilities, and they will help you. They will help you navigate the schools and navigate where to go. We'll skip this part. And we'll open it up to questions. And I just want to tell y'all that we do have a behavioral health echo. There is a provider to provider consultation line. So if you're in practice out in Franklinton or Opelousas or anywhere, you can call this line and they will connect you with a behavioral health provider to help you navigate behavioral health cases. So let's open up to questions. We have like 3 minutes.
So it means that they can have ADHD and concomitantly opposition defiant disorder as well.
Yes, you can. You can have both. The whole part of that though is like the ADHD tends to be easy to treat and respond to medication. The oppositional defiant is not going to respond to medication. It's not the easy thing to treat. That's the more difficult thing to treat.
Okay. Okay, thank you. That was very good. Thank you very much. Really appreciate your lecture. Thanks.
Thank you for coming this evening.
Does anybody else have any questions?
Anyone have any cases you want to talk about? I can stick around a little longer too.
Let's see. Dr. Daniels asked, would it have been appropriate to give both preliminary diagnosis of ODD and ADHD in this patient?
Absolutely. So, actually, here's the thing about ODD, because we didn't get into detail about ODD too much. ODD can be diagnosed in one setting. So if the parents are reporting ODD symptoms, it's ODD. And then like the way that DSM breaks down ODD, it's mild if it's one setting, it's moderate if it's 2 settings, and it's severe if it's it's 3 or more settings. So ODD can be diagnosed in one setting. So that for that case that I showed, that's a diagnosis of ODD with a preliminary diagnosis of ADHD.
Gotcha. You're getting excellent lectures. Thank you. Thank you. Great information. Thank you. Anybody have any questions? I do encourage y'all to, oh, wait, we do have one. Can you share some of your experiences with the longer acting Strateria? Is that right?
Oh, sure. Okay, y'all. Strateria, I shake my head like this because in theory, it should be a great medication. Man, I have trouble with it. I can't get past side effects. Like, and if you talk to like my little Facebook forum group of child psychiatrists and stuff, they all have the same issue. Like there's non-stimulant, like specifically atomoxetine as a medication has a lot of side effects, a lot of stomach aches, headaches, dizziness, even at the low doses. So it's a tough medication to do, but it does have a place if you can push through those side effects, because those side effects do get better with time. They do go away. If you can push through and get a kid to stay compliant on it for 8 weeks or more, it tends to work. We were excited about Quellbry though, like having something 2 weeks. Okay, we can try it for 2 weeks. If it's not working, we can get rid of it and try something else. So Strateria has been a difficult medication, I won't lie.
I do encourage everybody to complete your evaluations. For those who are, thanks so much. We had some, other physicians join us, not just LAFP members. So welcome. Thank you. I appreciate it. For the LAFP members, I will, report your CME to AAFP, and everybody, I will send your CME certificates. It'll be tomorrow or Monday when I get those to you, but you'll be able to claim credit with the CME certificates that I send you. Dr. Olivier, I don't see any other questions. I thank you. This was an excellent lecture. We'll have to try to get you booked for next year. So great job.
Next year we'll talk about oppositional defiant disorder.
It sounds like there's a lot of need for that. So yeah, good deal.
It's the face slapping diagnosis. It's like, oh, here we go.
Yeah.
Okay.
All right. Well, I guess if that is it, we will let everybody go enjoy the rest of your evening. Thank you again so much. I appreciate it.
Thank y'all for those who came. I appreciate it.
Yep.